Hello, everybody. Welcome back again. My name is Dr. Sami Alam, physician educator, healthcare consultant, founder and CEO of DextroMedical, and associate professor of medicine. Today, we will talk about what is a hospital risk. Why is hospital risk? Because it's very important to understand from an educator perspective. But today, we'll be talking about something that affects every hospital, every clinician, and every patient. And whether we acknowledge it or not, hospital risk is just not limited to malpractice or to lawsuits. It is an invisible force that determines whether hospitals are paid accurately and whether quality scores improve or decline. And so in less than 20 minutes, we'll teach you about that skill set. We'll teach you how to teach others about hospital risk. So let's get started. First part of our video today, we'll be discussing what is a hospital risk. Hospital risk is basically the probability that a hospital will experience some sort of harm, whether this is financial, whether it's clinical, whether it's legal or reputational, and due to failures in care delivery, documentation, systems, or communication, that risk can happen. There are 4 core domains when we talk about hospital risk. The clinical risk, and that's obvious harm to the patient. The financial risk, it's basically the loss, revenue, or penalties that the hospitals get. Regulatory risk, that's the audits, the citations, the compliance issues, and compliance failures. The reputational risk, and that's basically the public trust and performance rating. We talk about the star rating, CMS, Leapfrog, and these are all telling to the public how good of a hospital you are and if you're doing the best to the best of your abilities to provide that quality care to the patient. So these risks are interconnected. They are not in silos. It's all a cycle, and we want to make sure that we break it down for you to understand it. So the first point that we'll be discussing today is the clinical risk. And clinical risk is really the foundation of the hospital risk. It includes missed diagnosis, delayed recognition of severity, fragmentation of care, fragmentation of hands-off, and under-recognized complexity. And CDI, if you want to discuss a little bit more about clinical documentation integrity and how it plays a role, understanding and getting the recognition of the complexity, we can discuss that with you. But most clinical risk today is not due to lack of effort or competence. It's due to the complexity. The complexity of care is not really showing. Patients are older, patients are getting sicker, and patients are really getting readmitted to the hospital with the same cause. When complexity is not recognized and documented, risk can escalate. The next point that we'll be discussing today is the documentation as a risk multiplier. What that means is documentation is not just a clerical work, it's a risk translation. If a condition is not documented, it does not exist for the payers, for the regulators, for the quality measurement, or the legal review. Under documentation is one of the largest hidden drivers of a hospital risk. And I'll give you an example of that. Patients don't get admitted to hospitals with signs and symptoms. For example, chest pain, headache, abdominal pain. All these are hidden risks for underlying conditions. If that underlying condition is not well documented, that will impose risk. And that obviously from the patient safety perspective, not only that from the financial perspective. The financial risk is one of the drivers too, and the financial risk include revenue leak, denial management, value-based penalties, and missed incentive payment. What that means is if a hospital is providing quality care, they will be incentivized by different programs. They call it the value-based programs. If a hospital is not performing up to par, they will be penalized. There is so many readmissions for the same cause, or if the hospital is having post-operative complication of care, that may cause that the hospital will be penalized. Financial risk, hospitals are paid based on documentation risk, not necessarily the effort. And when acuity is understood, hospitals appear efficient. But if the acuity is not understood, hospitals will appear inefficient. Outcomes will be worse, and risk-adjusted performance declines. And oftentimes we get the question from hospital administrators asking why case mix index is acuity measurement that every hospital should understand and know. And the reason why is because risk is not adjusted. Now, most of the risk adjustment post-discharge may not be necessarily useful because it's happening after the fact. So it's helpful for hospitals to do a preemptive approach for risk and risk adjustment. Regulatory and legal risk is very important to understand. Regulators do audit the documentation and they do not audit the intent. What that means is if it's documented, it happened. If it's not documented, it didn't happen. Intention, unfortunately, you don't get penalized or rewarded for intention. So if there is a documentation of certain kind of illness, you should be at a hospital, be able to understand it, document it. Your medical team document the risk. And in more videos, we'll be discussing how to document risk once you see it. The legal exposure grows when documentation lacks the clarity, consistency, or the severity. When we talk about clarity, that means that the diagnosis is clear. If it's first onset or an exacerbation of a current illness, consistency that has to happen over time. If the patient has a chronic condition has to be captured, reported, and the treatment progress should be showing on the patient past medical history. And for the consistency and the severity is measured by mild, moderate, severe, and extreme. And risk of mortality is measured by mild, moderate, severe, and extreme. And so therefore, that level of severity should be captured. We illustrated by if the patient is having an illness, that illness can be the shallow end of the lake or the deep end of the lake. And that illustration really shows whether the patient is mild in their illness, moderate in their illness, or severe in their illness. In legal reviews, documentation is treated as fact. So therefore, anything that you put in your medical record, you should be able to track it, remember it, hopefully put some information that shows the hospital the effort that you as a provider or care team has exerted over time to help this patient be discharged safely. And CMS does look into those. How hospitals reduce risk? This is a very important question, and I feel that everybody should understand that. Those who are working in quality management or risk management. Risk reduction begins with early recognition. It's always preventative in nature. Real-time documentation, integrity, and interdisciplinary alignment. Physician education is a very important piece in this area, and each hospital should dedicate a physician educator that understand and can communicate in physician terms, risk management and risk adjustment. Hospitals that manage the risk will design systems that capture reality as care being provided, not post-fact, not after the patient is being discharged. And in closing, hospital risk is about accurately representing the patient complexity. We want to have that reality visible. Patient in the hospital should be discharged safer. Hospitals are paid fairly, and quality metrics should align with the care that is being provided. I thank you so much for listening today. On next episode, we'll discuss a little bit more about those concepts and break it down to the listeners. If you want to understand a little bit more about hospital operations, please subscribe to my channel, or feel free to contact me on the website that I will be attaching in the link below, or by sending me an email. But thank you very much.